Basically, a question to Karthik यार 10 साल पहले when you were driving in an unknown city to go to one lane and one place, क्या करते थे? लोगों से खिड़की उतार के पूछते थे भाई बाएं कैसे जाना है, दाएं कैसे जाना है. That's what you used to do. How do you drive now, Karthik? If you come to Kolkata and I give you my car, how will you drive? You'll tell me later, but you'll use my GPS map. Tell me that, right? So that's exactly what CGM does, right? It gives you a GPS map and tells you about unknown patterns. So why are you not going to use it? Is there even a reason for having a debate about this? I don't know. But let me put my point forward, and I'll be like Sprite, seedhi baat, baki all bakwas. So I'm going to only put evidence, and evidence in this, and nothing else, and some real world examples going forward. So the motion is CGM should be used in on and all even before initiating therapy in every drug naive type 2 diabetes patients, because it is cost effective, it gives a baseline assessment, patient empowerment is done, long-term outcomes have been shown to be good, and there is good therapeutic decisions, personalized and precision therapeutic decisions that you can take for your patients. This is a current global burden. We know that, and we've been seeing this slide from morning, and we know that it's very difficult to give precision medicine with this burden all around. What are the limitations of traditional monitoring? We know it's limited data points are there, nocturnal patterns are missed, asymptomatic hypoglycemia, unaware hypoglycemia is often missed, patient poor compliance is often there, and inadequate baseline is very, very important. What CGM does gives you a comprehensive capture of the data, real-time readings and trend patterns, the up and the down arrows, and gives you an understanding of the glycemic variability, which is very individualized for every individual. Now let's come to the evidence. We have evidence to show that CGM improves glycemic control in the whole spectrum. One meta-analysis, as I speak, 26 RCTs has been compiled to show the improvement in HbA1c, in improvement overall. And it improves glycemic variability. That is important when you're starting a patient initially who is a new onset diabetes, who is drug naive. You want the patient to understand how their sugars are behaving, and this is exactly why you need to do a CGM even before initiating a treatment. Perhaps it gives you an insight to choose the right drug for the patient after doing the CGM. So patient empowerment will be the key. This is one such study that tells CGM has been rated as the most significant intervention element that makes a difference. It tells the patient to act at the right point and make changes in his day-to-day activity. So it acts as an empowerment tool. Behavioral change. We always know that diabetes is a disease that can be altered with behavioral modification, and what's best than having a GPS map telling you how to behave in a better way. So this is a scoping review that tells you that CGM drives lifestyle modification by giving proper behavioral evidence and behavioral change. Most important is real-time feedback, and this is important in diabetes care, especially in a drug-naive patient who is getting started with diabetes, starting to understand his disease. This is exactly where you need real-time feedback on food choices, exercise, sleep and stress, timing of how to go about with your lifestyle, and even with medication as you go along in your journey of diabetes. There is evidence to show that CGM can help improve their dietary patterns by giving personalized dietary recommendation, and this is something that I strongly follow in my clinic. We do CGMs and we have personalized nutrition plans given to the patient as they go along, and there are a lot of studies, as I'm showing you here, which says that we have statistical significant data on these points that I'm speaking about. We know CGM is safe, right? It doesn't cause much problem, no serious events. Cost is, of course, what Karthik will say is a challenge. But having said that, long-term costs are much less if you're using it in the right way. Now, what about drug-naive patient? Now, this is important. When the patient is drug-naive, you're probably in a phase where you're pushing lifestyle modification, or you're in a decision-making scenario where you want to choose the right drug for the patient. So this is exactly where you can use it to recognize variability, to assess the risk, and give targeted therapy. We are talking about personalized and precision medicine as we go along. In newly diagnosed population, another RCT which has been published as an abstract, and this goes on, it's a small RCT, 31 newly diagnosed intervention study, and it shows short-term use of CGM providing valuable insights for glycemic management. Now, Cost effectiveness. This is what Karthik will talk about. But if you look at the long-term cost benefit, it's like investing in a mutual fund. This is what I tell my patient. You invest today, you reap the benefits of it tomorrow because it cuts down on your complication by improving the glycemic variability. So even if today it pinches on your pocket because diabetes care in our country is out of pocket, in the long term is going to cut down on your cost. And this is a paper published, and it looks at the data from the US, but it definitely improves the quality of life and cuts down on the cost in the long run. So it is not a costly affair, it's a cost friendly affair if you look at it in the best in that perspective. Most importantly, having a pattern understanding gives you optimization of the resource. Whether the patient needs to be with the doctor all the time, patient needs to be with the nutritionist, patient needs to make changes in the education, or needs to be more with the doctor. All this better decision making can be done if you have this graphical understanding over a long period of time. And in the long run, if you're able to implement CGM in the right time, then you're improving their long-term complications by reducing the risk of microvascular complications going forward. Indian population. Now, there are a lot of study, and this is one study by Dr. Vitul Gupta that I picked up, and thanks for publishing this. He looked at this 649 Indian patient, and he found that, there's a real world evidence even in India. Even we conducted a study on type 1 diabetes population, which goes on to show that there is behavioral change happening. But my context was type 2, so we didn't quote our study, we quoted Sir's study, and that's a fantastic result that he has brought out. Cultural consideration. This is very important in India. We are a diverse country, high carbohydrate diet. Cultural practices are different. There is fasting and feasting that we keep talking about. Family gets involved. All these nuances can be picked up if you are putting the patient on CGM when they're learning about their disease, when they're drug naive, when they're early into the disease. There's no reason why you should not be doing that. And the guidelines strongly recommends the use of continuous glucose monitoring across the board. We do have recommendations advocating the use of CGM, and definitely it should be used even in drug naive patients when they're in the initial phase of the disease. Is it a primary care feasibility? Can be done in a primary care setting? Now, this is a paper that gets published when 520 primary care type 2 diabetes patients that says CGM implementation in primary care setting demonstrate that this technology is not limited to specialty practice. Cost, leave aside. It's a simplistic technology, can be implemented even in a semi-urban rural setting with a little bit of education and guidance to the patient. Real world case. Now I'm talking about all evidence. Last 2 minutes, I'll just show you some case examples. So this is a 45-year-old patient who is a newly diagnosed type 2 diabetes, drug naive, came in with an HbA1c of 8.5, fasting blood glucose of 160, and the patient was initiated for 14 days continuous glucose monitoring graph, and it was sequentially followed up for 3 months. And take a look at this. This is the first month's continuous glucose monitoring of the patient, just helping the patient understand the pattern, simplifies the problem, and encourage the patient to stay on lifestyle modification and control their disease better. So this is the first graph. Take a look at the subsequent improvement in the continuous glucose monitoring as the patient continues in the next month, and then in the third month you can see much improvement. And all this, the patient is only on lifestyle modification, and just because he's got a GPS map to tell him that this is how your sugars are behaving, he's able to manage it by understanding his or her condition better. And finally, you can see this particular patient almost attain normoglycemia with minimal glycemic variability, only on lifestyle modification, because this patient had an idea how his sugars are changing with his eating pattern, sleep pattern, with the way he's living his lifestyle. Another interesting case, and you can see here, this is a type 2 diabetes on lifestyle modification on 3 months with an HbA1c of 7. Patient put on a CGM. Take a look at the first week and the second week, and we always see this in our practice. In the first week, the CGMs will show variability. In the second week, the variability improves because the patient has an understanding of his or her blood sugar findings. So the early intervention is the key. We say hit the disease hard early, hit it with the proper monitoring tool as well. Clinical implementation strategy is very, very important. So in initial assessment, we should have continuous glucose monitoring in the early phase, even in a drug naive patient. And of course, some counterpoints to Dr. My dear friend here. He will talk about the cost, the complexity, the patient acceptance, but trust me, these are not the limitations. The limitation is the inertia that we don't want to try something new for our patient. So we need to come out of this inertia. If we are coming out of this inertia, I'm sure these things can also be overcome as we go along. Future is bright, and I keep talking about AI and everything. Now you're going to get not just current analytics, we're going to get predictive analytics with AI. Would you want to give that to your patient using a continuous glucose monitoring right at the beginning? So I will close with this. The last slide is that it gives a superior assessment. It empowers the patient. There is enough evidence which I showed you and real world evidence which can tell it is safe, the guidelines support it, it is cost effective in the long run. Then why not use it, my friend?
Thank you. Thank you.